The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies. But I could. Big Pharma, where you at? But, alas, I have no financial disclosures. Okay, on with the show. Hello, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. I want to talk about statins today because I'm finding myself having this conversation a lot recently with patients. A lot of people are coming in and, if not overtly pushing back against being put on a statin or continuing to take a statin, then questioning. I'm hearing from so many people, hey, I'm hearing a lot of bad things about these statins. Do you think this is a really good idea for me to take this? Which is always a legitimate question, obviously. And I would like to understand some of where those concerns are coming from. I've noticed that it's much more polarized than your typical discussions about risk versus benefits of particular treatments or medications, because the contrast between what we're hearing from the professional medical societies and then whatever it is that patients are going and finding elsewhere is very stark. I try to base my practice on legitimate guidance from professional medical societies, regulatory agencies, that is ostensibly based on good evidence. Of course, we know that not everything has high-quality evidence behind it, but I generally believe that those societies and regulatory agencies are doing the best they can and putting out the most reasonable information for us to go by. So you hear from the American College of Cardiology and the American Heart Association and the USPSTF, statins are good. You should be putting people on statins. They save lives. This is your first line of defense against major adverse cardiac events, period. And then evidently people are going elsewhere and hearing, these are bad for you, you should get off of these. It feels like politics. It feels like you have one side that's very polarized one way and the other side that's very polarized the other way. And usually in those situations, that means the answer lies somewhere in the middle. Because that's reality, right? That's where everything lives. That's where all of us live. We're in the gray area, somewhere in the middle. I think a good rule of thumb is that if you're hearing something that inflames you, that makes you mad, makes you upset or scared, you're probably not hearing the whole truth about that thing. Whether it's a political issue, a social issue, a medical topic, whatever, everything has good and bad. Everything has risk and benefit. And if anybody's telling you, no matter which side they're on, hey, I know the answer, this is simple, they're definitely not telling you the whole truth because nothing's simple. But unfortunately, that's what we look for. I think it's human nature to look for who is going to be out there confidently telling me the right answer that I can absorb in the least amount of time possible. So it's easy to understand why people who give information like that become popular. And I think to us as reasonable medical people, it seems kind of ridiculous when somebody's coming in saying, I'm not doing this because whoever, Alex Jones, told me not to. That sounds so crazy to us, right? But at the same time, if you're coming into a medical office and being told, well, I'm your doctor, I know what's best for you, how dare you question me? That's not ideal either. I'm really not good at answering patients' questions when they say, tell me what to do, because I'm here to give you my opinion, my hopefully reasonable best guess about what to do or what I suggest you should do. But at the end of the day, you're the person that has to live with the consequences of that decision, not me. So it's ultimately up to you. And I want to know what you think and what you prefer and what's going to work for you in your life. Because if there's no way in hell you're going to take whatever medicine, there's no point in me prescribing it. If you're not going to go for whatever procedure or treatment, there's no point in us doing all the paperwork for it. Sometimes it seems like people think we want to throw a bunch of medicine at them and that our goal is to get them on a whole garbage bag full of medications. I'm sure I can speak for pretty much every medical provider when I say that is not true. There's no incentive for me to write a prescription other than I think this is the best thing to do for the patient. And I love it when we can clean medicines off of a patient's list. When someone comes in and says, hey, I stopped all these medicines, I'm like, great. It's less work for me. It's less liability for me. Fantastic. And I think that is part of why people have the impression that they're going to get yelled at about losing weight every time they walk into a medical office. I make a point not to do that in my medical practice. I don't usually even mention weight unless somebody asks about it or is interested in it, or it's just very pertinent to whatever we're talking about. I try not to be that person who says that to everybody who walks through the door. And that's mostly because I'm somebody who struggled with weight my entire life, and I know what that feels like. But I also know as a medical person, and having seen it happen over and over and over again, that when people do improve their diet and start exercising more and lose weight and get more sleep and address their mental health, a lot of these problems that we deal with get better. So I get why you might focus on that. And in a roundabout way, that is us saying, hey, we don't necessarily want to put you on all these medicines. We want you to make lifestyle changes that make these problems better without having to do that. So anyway, statins. I thought I'd spend a bit of time talking about where statins came from in the first place. It's only been a little more than 100 years since someone figured out that cholesterol has a role in atherosclerosis, and the credit for that hypothesis goes to Nikolai Anichkow. He published his experiments back in 1913. We had more studies, most notably the Framingham Heart Study that probably everybody has heard of, that suggested more strongly that cholesterol level was associated with cardiovascular risk. And by the 1950s, 1960s, it was pretty well accepted that we needed to address cholesterol as a risk factor for coronary heart disease. The earlier lipid-lowering agents, things like nicotinic acid, cholestyramine, estrogens, and dextrothyroxine, didn't work all that well and had a lot of side effects. The breakthrough that led to statins happened in 1976. A Japanese biochemist named Akira Endo, he isolated mevastatin that was produced by a fungus, namely Penicillium citrinum. So that was the first statin. And of course, the formal class name for statins is HMG-CoA reductase inhibitor. So they tested it first in rodents. It didn't work so great. Then they tested it on chickens, and it worked really, really well. So then in human trials, it was shown to be pretty effective at reducing LDL. The first study that proved that was in 1981, where a study showed that this mevastatin could reduce LDL by about 29% in patients who had familial hypercholesterolemia. The next one to come along was lovastatin. This was in the late 1970s, and this was the first statin to actually be approved by the FDA. And then over the next couple of decades, from the 80s through the 2000s, all the rest of them came out. So those would be simvastatin, pravastatin, fluvastatin, atorvastatin, cerevastatin. This was taken off the market in 2001 due to high rates of fatal rhabdomyolysis, especially when it was combined with gemfibrozil. So that's one of the big things that made us realize we should not use gemfibrozil and statins together. After that was rosuvastatin and then pitavastatin. Around the same time that these were all coming out, we have trials being done. The big ones would be 4S in 1994, WOSCOPS, WOSCOPS in 1995, and HPS in 2002. Together, those three studies looked at about 30,000 participants and provided a lot of evidence for the safety and efficacy of statins. And then, of course, there have been more and larger studies and trials in different populations. If you enjoy that sort of thing, there's a good graphic in my reference document here that I'll post that is a timeline of when all these different studies happened. That's from the Journal of ACC from April of 2020. And the guidelines have incorporated statins and been pro-statin ever since. And with our most recent guidelines from ACC and AHA, we're also seeing the newer agents being integrated. That would be ezetimibe, PCSK9 inhibitors, and bempedoic acid to be used as adjuncts to statin therapy or alternatives for people who can't take them. So that's where we came from. So at this point, we have roughly 40 years of data supporting the benefit of statins when it comes to preventing adverse cardiovascular events. I'm not much of a numbers guy. I don't quote study results and all this to my patients because I can't keep all those numbers in my head. But here's some numbers that are our core base of evidence about statins. This comes from the Cholesterol Treatment Trialists Collaboration, which are meta-analyses that cover about 27 different trials and about 175,000 participants overall. And that information shows that for every 1 millimole per liter, which is 38.7 milligrams per deciliter, that you can reduce the LDL cholesterol you get about a 21% proportional reduction in major vascular events, those being non-fatal MI, coronary death, stroke, and revascularization. The benefit is dose dependent. If you get a 2 millimole per liter reduction, that leads to about a 45% risk reduction. All-cause mortality goes down by about 9% for every 1 millimole per liter. You can reduce LDL, and those benefits are pretty consistent across subgroups, meaning gender, age, comorbidities. As for secondary prevention, meaning people who have already had an event, the 4S trial showed a 42% reduction in coronary death in people who have already had an MI or who have angina. The HPS study showed a 24% reduction in major vascular events. So what that translates to in absolute terms is that treating 10,000 high-risk patients for 5 years and achieving a 2 millimole per liter reduction in LDL prevents approximately 1,000 major vascular events. And we have data that suggests that intensive statin therapy does have benefit over moderate intensity therapy. This meta-analysis involving the Prove It, A to Z, TNT, and IDEAL trials, which covers about 27,000 participants, showing about a 16% reduction in coronary death or MI in high dose versus standard dose statins. There's a little table in my reference document here that lists relative risk and absolute risk difference for these different outcomes that we're looking at. I'm not going to read those numbers because I don't really have a great understanding of what they mean. I do like number needed to treat. That's a number that I can understand. Like, you have to treat this many people to have a good outcome. So this data is from a 2022 USPSTF systematic review covering 22 trials. The number needed to treat over between 1 and 6 years for statins for all-cause mortality is 286. For MI, both fatal and non-fatal, is 118. For stroke, both fatal and non-fatal, is 256. Composite CV outcomes is 78, and revascularization is 169. So just thinking about our medical practice, I think we have roughly 5,000 active patients. So if we're treating all of those people, and we're not, obviously, if we're treating a large percentage of those people with statins, there's no question we're preventing adverse cardiovascular events based on this data. There's an even more detailed breakdown in my reference document here from JAMA that summarizes trial data on all these different outcomes. This is from December of 2013. As far as long-term benefits, that WASCOPS trial has a 20-year follow-up that demonstrated that being on pravastatin for 5 years was associated with a 13% lower all-cause mortality, 21% lower cardiovascular death, and 35% fewer heart failure hospitalizations over that 20-year period. So to me, that's a pretty robust body of evidence that suggests that statins are good. So now I want to try to cover some of the concerns about why statins are not good. And I'll just go ahead and say my bottom line conclusion at the top of this here, because it really hasn't changed after reading about all this. Every medicine has risks and benefits, and that's certainly true for statins. Yes, they cause some adverse effects. Most of the time, the benefit that you're getting from them way outweighs the risk of it causing a problem. And that's going to be true of every medicine, every procedure, everything you do in life is a risk-benefit situation. I mean, if you take enough Tylenol, it will kill you. If you drink enough water fast enough, it will kill you. We drive around in our cars all the time, mostly not thinking about how we could be seriously injured or killed in a car accident. The electricity in your house could kill you. Your house itself could collapse on you and kill you. There's nothing that's without risk. And I think that is what people kind of struggle to understand, risk versus benefits. I keep waiting for the other shoe to drop on these GLP-1 medications. The clamor of people to get on those medications to lose weight is unreal. Every once in a while, somebody will come in and say, "What do you think about these GLP-1s? I'm not sure if I want to jump on this bandwagon or not." But the vast majority of people are like, "Please give me one of these medicines. I hope I'm diabetic this time so I can get on one of these medicines." Unbelievable. Which suggests that most people's risk-benefit analysis of weight loss medication puts losing a significant amount of weight way above any drawback or adverse effect that medicine may cause. But evidently, that's not how people think about statins. So let me go through some of the common bad things about statins that are out there and look at whether or not there's evidence for that and how common those things are. And to be clear, I'm not an arrogant person. I'm not an arrogant clinician. I'm very much not here to say statins are good, shut up and take it. We always have to be open to new evidence and new ways of thinking about things. If it turns out that statins are causing more harm than good for some reason, well, we need to not put people on statins. I'm certainly always open to that. And I'm never going to sit here and say, well, this that we're doing is 100% the right answer. I don't know. We'll find out. I'm not out there doing the research. I think unless you happen to work at a big academic center or your focus is on research, most of us are just out here trying to do the right thing for our patients. So if the guidance changes, if the evidence changes, we'll change our practice. We should. That's where I'm coming at this from. So what are the common things that people experience or are afraid of experiencing? Number one should be muscle pain. I've definitely seen a lot of people come in complaining of muscle pain who are on statins. And normally my first move in those situations is to have them hold the statin to see if that's what's really causing it. The evidence seems to point to statins mostly not causing muscle pain that people feel. We have these trials that kind of like trick people into thinking they were taking a statin when they're not. And it seems like a lot of those people reported muscle pain even when they were not on a statin, or the muscle pain that they were reporting remained even while they were not taking a statin. So the conclusion there is that most of this was not true. That's not how I operate in the real world. If my patient says they're hurting, I believe them. The actual data seems to show that statins cause about a 3% relative increase in first reports of muscle pain or weakness. And during the first year on a statin, it seems like about 1 in 15 of the muscle symptoms that were reported were actually caused by the statin. Actual myopathy, which means a CK level greater than 10 times the upper limit of normal associated with symptoms, happens in less than 0.1% of patients, so about 1 per 10,000 per year. Rhabdomyolysis is rarer than that, at about 2 to 3 per 100,000 per year. There is a serious complication called statin-associated autoimmune myopathy. The rate of that is about the same as rhabdomyolysis, 2 to 3 per 100,000 users. And that's a condition that persists after the statin is stopped and actually requires immunosuppressive therapy moving forward. New onset diabetes. There's a thought out there that statins cause diabetes. There's a meta-analysis from 2024 that found that low or moderate intensity statins increase diabetes risk by 10% and high intensity statins by 36%. The absolute annual excess risk is about 0.2%, and that's driven by glycemic shifts of 0.04 millimoles per liter and A1C increases of 0.06 to 0.08%. And it seems like that mostly happens in people who were predisposed to becoming diabetic anyway. About 62% of these new onset diabetes cases were already in the top quartile of baseline glycemia. So bottom line there, if you are prone to developing diabetes, and obviously a lot of people who get put on statins are going to be prone to developing diabetes, they do slightly increase your risk of going over that threshold. In terms of actual numbers, it still seems that the cardiovascular benefits outweigh the diabetes risk. For every 255 patients treated for 4 years, 1 additional diabetes case occurs, while more than 5 vascular events are prevented. Effects on the liver are another thing that we worry about. It seems like elevation in the transaminases, that's defined as more than 3 times the upper limit of normal, happen in about 1% of patients taking statins, and that is dose-related. The higher the dose, the more likely the transaminase elevation. That doesn't mean that it causes liver toxicity. About 70% of those elevated transaminases are going to go back down to normal if people just stay on the medication. Clinically significant liver toxicity happens in about 1 in 100,000 patients. There used to be a requirement issued by the FDA to monitor liver enzymes in people taking statins, but that was actually lifted in 2012. The only suggested monitoring is a baseline ALT. How about that? And stable chronic liver disease, including MASLD, not a contraindication for statins. Drug interactions are another thing we worry about. The statins that are most prone to that are simvastatin and lovastatin because they are extensively metabolized by the CYP3A4 system. Some of the other statins, rosuvastatin, pravastatin, and fluvastatin, have minimal involvement with that CYP3A4. We know to avoid doing gemfibrozil with any statin. And then if you have strong CYP3A4 inhibitors like azole antifungals, macrolides, or HIV protease inhibitors, you would want to stay away from those with simvastatin and lovastatin. Also cyclosporin you would want to avoid with simvastatin and lovastatin. This is just off the top of my head, but if I remember right, I think there was a thing during COVID where we were telling people to stop their statin while they were taking Paxlovid. That was one of the frequent ones that came up. All right, what about this idea that statins cause dementia? The FDA did make a label change in 2012, noting post-marketing reports of memory impairment. Those were based on case reports, not trial data. And we do have randomized controlled trial evidence that overwhelmingly refutes the idea that statins cause cognitive harm. We have a meta-analysis involving 25 randomized controlled trials, that's 46,000 patients, that showed no differences in statin and placebo as far as adverse cognitive events or worsening cognitive test scores. There's a trial called Ebbinghaus that found no cognitive impact, even with very significant LDL reductions down to less than 25 milligrams per deciliter. There's observational data that actually suggests there might be a reduced risk of dementia associated with taking statins. So the thought on this is that we really should not worry about that. What about statins causing cancer? There were some early rodent studies that involved supraphysiologic doses of statins and some isolated trial findings that spurred this thought. We have a meta-analysis of 27 trials involving 175,000 participants that showed no effect on cancer incidence or cancer mortality. We have a Bayesian network meta-analysis of 69 randomized controlled trials involving 238,000 patients that confirmed no association across all cancer subtypes. So we have a lot of data that refutes that idea. A lot of people want to take CoQ10 with statins, which is fine with me if it seems to reduce muscle pain. And I'll recommend that if somebody is having a bit of muscle pain and on a statin and doesn't want to stop taking the medication. We know that statins do reduce the circulating level of CoQ10. There's a thought that that reflects lower LDL transport rather than actual tissue depletion of CoQ10. And the evidence for supplementation is kind of equivocal. The current guidelines, the 2026 guidelines, actually recommend against routine CoQ10 supplementation. What about statins causing kidney damage? We have a meta-analysis of 33 randomized controlled trials involving 37,000 patients with CKD that found no significant effect on GFR or serum creatinine and actually found reductions in urinary albumin and protein levels with people on statins. Of course, rhabdomyolysis can cause acute kidney injury. So if you happen to be one of the 1 in 100,000 or 200,000 whatever people who gets rhabdomyolysis from your statin, that rhabdo can certainly damage your kidneys. There's an idea that statins cause neuropathy. We have a meta-analysis from 2021 that covers 150,000 participants that found no significant association between statins and neuropathy. There's an idea that statins cause erectile dysfunction or lower testosterone. I'm guessing that most of the male patients who come in and say, well, I've heard some bad things about the statins, this is probably what they're talking about. Obviously we need some cholesterol for things in the body, and one of those things is to make testosterone. So it makes sense in theory that statins could reduce testosterone levels. We have a systematic review and meta-analysis from 2024 that did not establish any clinically important testosterone deficiency with statins. We have a meta-analysis covering about 70,000 participants that found no increased risk of new onset erectile dysfunction among statin users. And one thing that makes a whole lot of sense is that having blocked arteries would cause erectile dysfunction. So you would think in general that treating vascular disease would improve sexual function rather than hurting it. Building on that, there's a general idea that maybe it's a bad idea to lower the cholesterol too much because, again, we need it, right? It goes into making cell membranes, other steroid hormones, bile acids, vitamin D, myelin. It's important for brain function. And as far as I know, we've never found any evidence that pushing the cholesterol really, really low is harmful. In other words, we haven't found the floor. Like, obviously, that does make sense that if you had no cholesterol and you were not able to do any of those things, it would be a problem. But so far, as far as I'm aware, there's no actual evidence of where that floor is. Pretty much, it seems like they always find the lower they push it, the more the benefit. There's an idea that statins can cause tendon problems. We've got a systematic review from 2016 that didn't find convincing evidence that that's the case. But there are certainly some observational studies that have suggested an increased risk for problems with the Achilles, problems with the rotator cuff, or some other tendon issues. There's a thought that statins cause depression, again, because of the brain needs cholesterol thing. That's not something we have seen evidence for. There was a recent analysis of adverse events from double-blind trials that was specifically looking for that found no convincing relationship between statins and depression. So those are all the specific statins are bad claims that I have come across that I want to say something about. I guess another thing that people probably struggle with, and I struggle with this from my side of it, is actually evaluating a person's cardiovascular risk. I think we as clinicians are probably a bit guilty of trying to simplify that too much in our head. We look at the LDL, and if it's high, we go, oh, you should be on a statin. What we're being encouraged to do, and what I am doing with really every patient I see, is to use a clinical calculator to figure out their overall cardiovascular disease risk and use that more to guide decisions about treatment. The latest and greatest calculator, of course, is the Prevent calculator, and I'll put a link to that in MD Calc. It's free. Anybody can use it. Really, if you know your numbers from your most recent lab work, you can go on here and calculate your own risk. You're going to need your total and HDL cholesterol, your systolic blood pressure, your GFR, which is your kidney function, and your BMI, which comes from height and weight. So if you have a lipid panel and a metabolic panel, you should be able to calculate that risk for yourself. So the idea that somebody who has very low cardiovascular risk overall, even though their cholesterol is higher than you might prefer, is totally valid. I was talking earlier about percentage of risk reduction. So you have to think, well, if somebody's risk is very high, if you have a 30% chance of having an adverse cardiovascular event in the next 10 years, and a statin can reduce that by 30%, that's a pretty significant number. If you only have a 1% chance of having an event in the next 10 years, putting you on a statin is not going to reduce your risk very much. I mean, it might still be 30%, but it's 30% of a much smaller number. So that totally makes sense. And we definitely take that into account in clinical practice. I would say mostly when we come across that, it's a younger patient, not on any medications, not paying a lot of attention to lifestyle, and maybe they have some elevated cholesterol and elevated liver enzymes, presumably due to fatty liver, or maybe they drink alcohol frequently that's causing that. A lot of those young people don't want to be on a statin, and we don't really want to put them on a statin either. So we encourage people to work on lifestyle modification and see what you can do on your own. And we'll think about this again in 6 months or a year or whatever. You also see the opposite. You have young people who come in and say, look, everybody in my family dies of a heart attack at 50, and I want to do everything I can to prevent that. And they're absolutely motivated to take a statin and push that cholesterol as low as they possibly can. And I think that's appropriate too. So like everything else, it's individualized decision-making, looking at the whole picture and taking into account what the patient wants. And then we try to make the best decision we can. So to wrap it all up, I think for me, the bottom line is most people who it would be suggested that they take a statin are going to benefit from that statin way more than they're going to have a risk of being harmed by that statin. I don't personally take one because my overall risk is low. I don't have really comorbidities other than being overweight. I don't smoke, and my numbers are okay. So I'm not taking a statin, but I would. 100% I would, and I would not be scared of it. So if you're a patient listening to this, if you somehow found this in your search for whether or not it's a good idea to be on the statin that somebody's recommended for you, I think do all the research you can, talk to whoever prescribed it for you about the situation, and make the decision that's right for you. At the end of the day, it's your choice, but I'd like to think that whoever prescribed that medicine for you has nothing but your best interest in mind and would not recommend something that they thought was going to be harmful for you. Okay, that's all I have to say about statins. I hope this was illuminating or reassuring or informative. I'm about to plug my book, Crooked Creek Serenade. It's out there. Check it out. If you're interested in tender, coming of age kind of stories, you are going to love it. I'm all over Instagram, Jody Marks Writes, and now all over TikTok. Same screen name, Jody Marks Writes. Follow, like, comment, rate, review, do all those things to help me out. It's fantastic. And same with the podcast. Thank you so much for listening. I hope you enjoyed the episode. I hope you have a great week. I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, and subscriptions really do help the show, so please take a second and do those things to help me out. If you have a request for an episode topic, or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.